Hello, Dr. Kelly Casperson and Dr. Peter Castillo. Welcome to the Jen Marples Show. I am so excited to have you here. And I know my listeners are going to be beyond excited to have you all here because we're talking about sex and why everybody deserves to have good sex. And, I'm talking about my women, my midlife women, and we want you to experience pleasure, not pain. It's like, raise your hand if you've had pain. That would be me. And we want to demystify what it means to be in midlife and have good sex, talk about solutions, and have you all walk away today knowing that you too can have good sex, A, and B, we're going to empower you to talk to your providers to get what you need. Because, let's talk about sex, baby. Okay, I just had to do it and I have a horrible voice. But thank you both for being here. I'm so honored to have you here. So this is your official welcome to the Jen Marples Show.
Thank you. Long time coming.
Seriously, long time coming.
Seriously. Your ability to herd cats is exceptional.
So Kelly and I were going back. We're like, we met for the first time at the very first Swell event, which was the meeting of the sort of the OG menopause minds from women from all different aspects of this fight. And we're trying to figure out how many years ago that was. And it's a little bit scary, but we did bring up a good point that even though it's been so many years, we've come a long way and we've also haven't gone very far. And that's why we need to keep having these conversations. And Dr. Castillo and his beautiful wife, Galia, I met probably around the same time so many years ago at a local event here in the Bay Area. And so then we've been chatting and wanting to collaborate for a really long time. And if you all are following me, we've just come off of 3 M Factor showings, of which Dr. Casperson was one of the stars. And so that was an amazing experience. And so we're bringing these two together. I was like, we need to have the two of them together because what was apparent is we've talked a lot about sex with women. I mean, not, you know what I'm trying to say. We've talked about the topic of sex with women.
You're like, don't knock it till you've tried it.
But not until you've tried it. Like, I know my listeners are progressive. I've got everyone. It's like, I'm just happy everyone's having sex. I don't care who with. But I wanted to have a male and female perspective because during these M Factor showings, what really came up, because this last, as you know, Kelly, they really showcase the men. They showcase the men in the movie and so how they can be supportive and have a talk. And so Peter is, not only is he a renowned doctor, but he's also a husband. And he hears a lot from, as you do, Kelly, from patients about it, how it's really hard to have these conversations with your significant others. And there's a lot of shame involved. So we're gonna erase the shame and the stigma. But before we get started, like I said in my intro, Dr. Kelly Casperson is a urologist and Dr. Peter Castillo is a urogynecologist. So just from the top, let's just define with you, Kelly, first, like, what is a urologist? What do you do?
Yep. So a urologist is a surgical subspecialist of the genital urinary organs, stereotypically taking care of men's pelvises, but all humans have pelvises. So from the top down, adrenal glands, kidneys, ureter, bladder, prostate, scrotum, penis, urethra, vagina, vulva, bladder. That's a big one. So urologists, it's a niche, meaning it's just those organs, but it's actually very, very big because it's bladder leakage, kidney stones, prostate cancer, adrenal cancer, sexual health, hormones, right? So it's actually a very big subspecialty because people will be like, oh, Dr. Casperson's into female testosterone and female sexual health. I just need to find a urologist. And I'm like, no. So you need to find one who specializes in hormones or female sexual health or male sexual health. There's plenty of male urologists who don't want to deal with male Viagra. So it's a niche, but within that niche, it's actually quite broad.
Okay, I love it. And you, Dr. Castillo.
Yeah, so as a urogynecologist, I'm an OBGYN based physician, and I did a fellowship in reconstructive pelvic surgery and female pelvic medicine. And it's a very long acronym, which was kind of funny that it's changed now. But nonetheless, our focus has been...
It changed back to how people wanted it to be it in the first place.
Right.
Remember at the beginning?
Really
they're like, we should call this Urogyne. And it was like, no, it should be called something else. And we're like, oh, let's call it Urogyne.
Right. Now it sounds weird because we got used to calling it this long acronym. Um, and because I'm OBGYN based, a lot of reproductive endocrinology plays a role in what we do as urogynecologists, though urogynecologists never really embraced women's hormonal care because that was generally in the general OBGYN realm. Um, and so we also deal with the bladder and below pelvic floor. So reconstructive surgery, including the bladder and the vagina, all the reproductive organs and all the support structures. But within that, its impact on sexual health is a big concern. Anything we do, whether if we do nothing for pelvic floor disorders, it impacts sexual health. Anything we do for those pelvic floor disorders can impact sexual health, oftentimes positively. And so that's where sort of we have a lot of overlap in the bladder and below part. I don't see men, except practice does see men's sexual health, but myself as a urogynecologist, I'm predominantly treat women.
Great. We need your expertise. We need everybody's expertise here. Okay, so we've laid the foundation. So let's get into it. And let's talk. We're going to, just so the audience knows, we're going to kind of go into a little bit about what's happening to the body, treatments, how to advocate for yourself, and then you are going to walk away empowered, like I said. So let's start with you, Dr. Castillo. So we mentioned this, like a lot, there's a lot of shame. Women are suffering. There's a lot of dryness. There's a lot, there's certain things and I also have endometriosis. My listeners know I've kind of been through it all. And so you think things are one thing, but they're really another thing. And I learned about vaginal estrogen, thanks to you, like Dr. Kelly talking about it all the time. Like, I need to get that up on in there. But for my personal, experience, and I know friends' experiences, women have a lot of shame, wondering why they can't have great sex anymore, why they don't want to have sex anymore, and what all of a sudden happened. Like everything kind of falls off a cliff. And we know there's that hormonal cliff and all that happens. So what actually is happening physiologically to us once we hit menopause? Because for me, it really hit menopause. So you tell me also if the physiological changes, especially with sex, also start in perimenopause.
Sure, sure. Well, there's a lot of barriers to care, especially when it comes to sexual health and pelvic floor disorders for women. Barriers start from physicians' lack of knowledge, especially in the generalist realm, or to community beliefs that this is normal. This is part of aging. Grandma has it, aunt has it, my sister has it. That's normal, sort of rite of passage. And then there's the shame aspect of, of women should never be talking about sex, and that should never be an issue. And to compound that, physicians were never trained in having these discussions. So aside from the barriers, understanding the why is a whole other part of it, and women aren't explained this. So, women have hormonal dependencies since puberty throughout. Hormonal decline starts between 30 and 40 in the realm of the testosterone decline by 50%. And as we've discussed and others have discussed, in how testosterone plays a huge role in libido, but it's a cognitive neural hormone. It behaves how it behaves on the brain. But sex drive is important if you're to reach climax and arousal. It's hard to get aroused if you have no desire. So between 30 and 40, data suggests that women lose about 50% of their testosterone production, which coincides with that onset of that perimenopause decade, that 7 to 10 year period where performance declines, both in libido, orgasmic response, memory, sleep, mood, drive, motivation, all the things that start getting impacted in those ages is certainly going to impact your intimacy and your ability to engage. So that's a big part of it. And then of course, this is assuming that there's no underlying concerns, meaning past traumas, childhood abuse, or really not a terrible relationship or medications that can impact sexual health. But assuming that those are all fine, healthy relationship, no medications, no health concerns, and no past traumas, you're still faced with the aging process. Interesting, in my practice, the average age of patient that shows up to my office with orgasmic decline or decline in libido is 44. It starts early. Now we have some as young as late 30s because of ovarian dysfunction or because they've been on birth control since they were 13. And then as late as others that are still having periods into their 60s. So, but average age is 44 in our population of patients in my practice.
Wow, 44.
Yeah,
I think
Seems
that's
well
very
really,
before anyone.
really important to hit home on. I want to put a pin in that for right now, because what I see so much is women say, my doctor said I can't have hormones because I still have a period. And what we need to make clear is the amount of hormones that your body needs to make a period is actually a very, very small amount. And hormone changes start happening well before periods end. So it's really breaking down that the periods are a permission slip for hormones or not, of like you having a period or not having a period is not the issue. It's the change in hormones, which happens years, we might say decades before periods end. So I want to just pause there for a second to point that out to people, because that is a myth and a perception that not only doctors perpetrate, but also women, of like, why would I go in for a hormone thing? I'm still having regular periods. Of like, periods are kind of an end sign of low hormones.
Okay,
I
well,
couldn't agree more with that.
yeah.
You know, women and patients in general aren't aware of these things because they were never taught. Physicians don't know this, and they keep repeating the same things that, you know, what you just mentioned. You're still having periods, therefore you're not menopausal. But changes do happen early. And there was some data to suggest that not only keeping women on hormonal replacement therapy after once they're in postmenopause reduces all-cause mortality. Recent papers showed that there was even greater reduction in all-cause mortality when started in perimenopause. So yeah, it's not wait till the shoe to fall off before you treat.
And I'll even add to that. I don't know if this is UK Biobank, but it was just published in a British medical journal that surgical menopause. So ovaries go in bucket on a Tuesday, right? Surgical menopause. If those people take hormone therapy, their mortality decreases by about 30%. So it's pretty profound, especially in the surgical menopause cases. And as a urologist, if the urologists cut off testicles and didn't give back testosterone, that would be malpractice. 100% of people agree with that. Yeah. We've got UK data, harder to do US because we're so disjointed. UK data of all the oophorectomies, so ovaries go in a bucket, and this was for non-cancer cases. So benign reasons that ovaries go in buckets in the UK, 5% are given hormones.
Wow.
With a decrease of 30% mortality if given hormones, 5% are given hormones. And I say this not because everybody's going to have surgical menopause, but you're going to know a sister or a cousin or a colleague or a blah, blah, blah to be like that. So young menopause and surgical menopause, starting on hormones, really, you know, we're all obsessed with longevity now. There is no better longevity medication out there for these people than estrogen.
So let's, Kelly, get into the three hormones. So we have estrogen, progesterone, testosterone. Mm-hmm. And so there's a lot of talk about all of them. We've probably heard the most about estrogen. Can you just talk about what each role each of those hormones play and the importance of each, and then what you've seen with your patients? Because anyone who's seen the M Factor, Kelly has interviewed her patients, and it's profound to see the difference with all these different hormones, especially with testosterone. But let's have a quick overview of all of those and the important roles that each play.
Yeah, so I always joke that estrogen's like Cinderella. Estrogen's like the fairy princess. She just got like all of the press, but she's important. But progesterone's important and testosterone's important. I wouldn't say anybody's more important for anything, but everybody's they're kind of like the Spice Girls. Like everybody's got a reputation, but they all tend to help things, and there's lots of crossover. Estrogen, progesterone, testosterone are all on what we call the cholesterol pathway, right? So they all you cut a carbon off, now you have testosterone, cut another carbon off, now you have estrogen. So they're all very similar. They're not coming from crazy different places. Testicles and ovaries all make these. Adrenal glands also make these. We also get a little bit of conversion in end tissue organs, but by and large, testicles and ovaries are the big producers of these hormones. They were called sex hormones. The bias in the name continues. They were called sex hormones because they were discovered in testicles and ovaries. but these are neurohormones, these are bone hormones, these are muscle hormones, these are anti-inflammatory hormones, as much as they are sex hormones, and you need them to reproduce, right? But I would say that's another stereotype that lingers, is that we call them the sex hormones. Like vitamin D is a hormone, right? So there's lots of things we don't even think are hormones that are hormones. All hormones do is they travel from one place in the body to another place in the body to help the body communicate. And I say hormones help healthy cells stay healthy. What that means is hormones aren't so great at treating disease. They're much, much better at preventing disease because they help healthy cells stay healthy. So if you just want to stereotype the Spice Girls very quickly, estrogen, very great for hot flashes, night sweats, joints, aches and pains, vaginal dryness. Progesterone, very, very good for sleep. Big myth is that you don't need progesterone if you've had a hysterectomy. The universe did not make progesterone in your ovary to only protect your uterine lining. It is active in the brain. It's active in the bone. It's active in muscle, right? And men have estrogen and progesterone also, right? So we made them very binary, but they're not. So progesterone's kind of your calm, chill one that helps you sleep. And then testosterone stereotype is libido. But you put an estrogen patch on a lot of women and they're like, my libido's back, baby. Like estrogen helps also, but testosterone stereotype is libido. Testosterone helps a lot in brain fog, clarity, quickness, decision-making, energy, helps some people sleep, helps some people be more alert. So that one's kind of out. Helps bone, helps muscle, helps joints, aches and pains a lot. It can also help hot flashes. So the important thing to know is these are not new discoveries that we're not sure if they're safe. Like we've been giving humans hormones for about 80 years now. They had a dark period between the years of 2002 and I don't know, 2 years ago, basically, right? Dark period, not because the data was all that bad, but because the media took the data, interpreted it poorly, and scared the crap out of everybody. And that took a good 20 years to reverse. Thank goodness for social media. Like social media, podcasts, physicians, patients, being able to try to right the wrong of this massive ship that kind of sailed.
Yeah. There was another stereotype to these hormones. Testosterone has a terrible stereotype, mainly because back in the 80s it was abused for professional sports and the Olympics. Of course, they became banned, it became a controlled substance. But the stereotype is that it causes people to be angry. If anything, testosterone is a mood stabilizing hormone. It is probably the best antidepressant mood stabilizing hormone there is. But its rap comes from high potency, high conversion of those testosterone, so testosterone converts to estrogen through a process called aromatization. That's where women get 15% of their estrogen from their own testosterone, from their adrenals and their ovaries, and men get their estrogen from. Men don't do well without estrogen. Neither do women. But when estrogen is too high and it's dominating testosterone, or it's the only hormone, it's sort of like having a powerboat with no rudder. And testosterone becomes the rudder, sort of helps stabilize the waters and keeps the moods. So I'm sure you've seen this, Kelly, how patients' partners always often report they're so much calmer at home now just by restoring their testosterone. But what's not recognized is how high surging and fluctuating estrogen affects mood so much, hence PMS. So estrogen, I find the most respect for, because too high or too low are not good, especially when it's fluctuating all the time.
Yeah. And the only thing I would add on that, just the wonders of testosterone, because again, everybody thinks it's just libido, and libido's great, but it's one piece of this. Dr. Louise Newsom published an abstract last year, 2025, looking at the ability to deprescribe both opioids and antidepressants. And she looked at this. People came in, she put them on estrogen. Some people were able to get off of their SSRIs. Then they started them on testosterone. Up to, I think it was about 30% were then able to deprescribe SSRIs, which antidepressants are notoriously difficult to get off of, right? Should you choose to. The power and the reason is these hormones produce serotonin. They produce dopamine. They help the brain. And so you're literally kind of restoring your natural health of the brain. And then people say, I don't need these other medications. So very powerful. And I think those are like the things that people who know, but it's not getting out into the gen pop of like, these are brain neurohormones. Their stereotype is sex, but what's our biggest sex organ really? It's our brain, right? So it's our brain neurohormones.
So we've got, all the hormones. We haven't talked about vaginal estrogen. We will in a minute. But so if someone's, starting out, like where's the point to start? Because we'll get into also non-hormonal treatment options for low libido and if you're having painful sex. So do we start with the patch? Obviously, you said we need progesterone if we have a uterus, but even if you don't have a uterus, it's great to have progesterone, testosterone. Where do women begin? And I just want to interject like my own experience with all this, having been in this world for 5 years. I was on a patch that was too high. It made me feel like I was crazy. I got scared, ripped it off. And I was very new into the process. And after listening to all y'all talk, it's like, something's really going on. I'm on like a low patch on progesterone. Then I had progesterone intolerance and then needed to get an IUD. So it's been, and I know just with having so many conversations with women, it's not get into the doctor's office and fix it and it's automatic. And it can also feel really overwhelming for all the women out there who are trying to get the right kind of treatment. So like, where do the average woman, where does she begin if she hasn't done any of this stuff? And she's like, holy shit, I'm in menopause or perimenopause. And I got a lot of stuff going on. And because this is a show about sex today, and I'm really bummed about my sex life. Like, where do we begin?
Do you want to start, Kelly?
Yeah, I would start with education. Get your books, listen to your podcast. My first book, You Are Not Broken. Nobody got good sex ed. We got a disease and pregnancy prevention plan. Right. And we'll talk about these amazing things, but no, they all have limitations. If your sex ed sucks, X, Y, and Z might not fix that. So I always start with education of like arousal. What's an orgasm? What's desire? What's responsive versus spontaneous desire? Are you scheduling sex? How's your relationship with your partner? How's your relationship with your body? Right. All of these things, because hormones will only do hormone things. Lasers will only do laser things. Non-hormonal options will only do non-hormonal options. The sex ed in and of itself is a big lift, but I like it to come first. Now, I joke, I worked really hard to make my clinic really, really easy because I've got books and podcasts, and my women are very educated now when they come in. So they're like, I've read all the things, give me all the things, we can go. But the average person, that's overwhelming. It's too many things. They don't have the background knowledge, right? So when you say, where do we start? I think the right answer is meet the woman where she is. Mm-hmm. If her big problem is I can't sleep, why are you trying to fix her orgasm? Right? As the first thing, let's fix sleep first. Sleep profoundly affects sex life. All right. So meet a woman where she is. Now, I believe if anything is preventative health in all of this discussion, vaginal estrogen is preventative health. Like, you will break the internet when we say, that your clitoris shrinks and your labia goes away after so many years of no hormones. And women are horrified by it. But then they're like, what do you mean I have to do this? It's kind of like flossing and brushing teeth of like, because we don't want the cavities to come, right? So the safety, the efficacy, and the low cost of vaginal estrogen, especially the cream, that of all the things of like what's just preventative medicine, vaginal estrogen is probably our lowest hanging fruit.
Okay.
What you said is very true. You really have to meet the patient where they are because there is no one test that tells you you're in perimenopause. You can look at labs for baseline, you can look at labs for guidance, but there's no one test for perimenopause because like we mentioned, they're still ovulating. So their FSH could be low, their estradiol could be high, could be higher than necessary. And their testosterone is just a baseline reading compared to the population. So they're not helpful in diagnosing. So it's about understanding symptomatology and where the patient is. Their level of understanding is a whole other thing. Luckily, nowadays, we've got wonderful authors that are creating great information for patients, and hopefully they read them. We pass them out as much as we can. We refer them out to purchase them online, but their education is very important. But really, it's understanding their symptomatology. So what we do in our practice is about first thing before they even come in, yes, we do have labs, but they have a full questionnaire that are all the questions that are never asked. everything from hormonal health to sexual health to pelvic floor health. And that way, when they come in, I already have an idea of where their problems are and their concerns are. And then I just ask them to prioritize them for me. Is it sleep? Is it libido? Is it energy, memory? Are they performing poorly at work or at home? And if I understand that, then we can tailor it to them, because hormone optimization or hormone restoration or replacement, whatever term you want to use, it's very nuanced. It's very nuanced. There is no one size fits all. There's a one size fits most, and there's always something that can be done. It's never about it's too late, or it's about well, come back to me when your symptoms get worse or you're not old enough. None of that dogma exists here anymore, belongs here anymore.
I love that. And I think, what I've instituted in my practice, and again, everybody's individualized, but by and large, if I want to speak in generalities, start low, go slow. Start low, go slow. I follow my patients. I see them back. We tweak, we pull. I call them pulling levers, right? We're going to pull this lever. We're going to pull this lever. But if you go from sea level to Everest Base Camp in one day, it feels very shitty. Right. And so that's where you see the bad reputations of hormones come from, is like, if you bump somebody up too fast, they might love it and then chase a steroid high, or they might hate it because you shocked the system and X, Y, and Z happened, whatever it was. So the body doesn't like big shocks. It doesn't like rapid weight loss. It doesn't like thyroid storms. It doesn't like sleep deprivation. It doesn't like starvation, right? It doesn't like running a marathon after not being trained. Body hates big shocks. So with hormones, start low, go slow. You can always move up. I mean, a lot of people, me, for example, I stayed on the same dose of testosterone for about a year before I went up on my dose of testosterone, right? So it's like, go slow, start low, and you can always go up. But it's like a haircut, right? It's like, don't take off too much at once. You can't put it back. So right. You can always dial back the hormones, but by then, like, now we don't trust them as much, or I got a bad side effect and it got a reputation. You're never going to be faulted for going slow, starting low, and adjusting over time.
Something just real quick to add to that is something I always tell my patients. I like to preempt things. Patients need to understand what the possibilities are. The whole consenting process is really about it, so they understand where their benefits are, what the potential risks are, what the potential side effects are. And so if by explaining them well in advance, let them know that coming down from hormones as you're going through creates symptoms, sometimes going back can create symptoms. So we're going to go slow. We're going to find that sweet spot for you. It may be different than your neighbor, but your sweet spot will find it. And by guiding them that way, they're patient. They'll wait for that result, as opposed to trying to shock them all right off the bat just to get a result. Then some of them you're going to lose because they're going to feel like, oh, that was an awful experience. I was better off before.
100% agree. I think the other thing we see on the internet a lot is, what's the right dose? What's the right lab value?
Yeah.
No, we're not all Toyotas. Lab values are not infallible. No. Right. So people are always looking for the right estrogen patch dose or the right testosterone lab. And I'm like, you check my testosterone 4 times today, I'm going to give you 4 different numbers, right? Really being with a clinician who understands that labs inform, but labs don't preach, right? Labs aren't the end all be all. And my 3-step takeaway for testosterone, for example, I think is very helpful. How does she feel? Does she have side effects? What's the lab value? In that order. In that order. Lab value doesn't get to come first, right? That's right. So it's very individualized, and labs for hormones, people don't understand this. Labs for hormones aren't like labs for kidney function. Like kidney function, very specific, steady state, narrow window of safety. That's kidney function labs. That's not hormones. Hormones fluctuate. How well did you sleep last night? What time of the day is it? Did you just work out? Right? How long since you last applied your testosterone? Right? Hormone labs fluctuate, and there's a much more greater variation in a normal range, but everybody thinks it should be like a kidney function lab, like this tight, narrow window that's optimal. It's like, no, that's for kidneys, not testosterone, estrogen, etc.
So 2 questions popped up for me. One is, there are a lot of women who cannot take or do not want to take hormones for whatever reason, because I know that there's the whole thing, I want to be natural and whatever. So what do those women do? Let's talk about the women
education.
who can't, maybe because they've had cancer or there's something going on and they cannot take.
I was just teaching at Harvard. This is the update all your listeners need. I was just teaching at Harvard, 1,750 clinicians. So for people to say doctors aren't trained, they're getting trained at a level that has not happened before. Like they're getting trained by leaps and bounds right now. 1,750 clinicians at Harvard for a full week learning about midlife, menopause, and hormones. On the Thursday, we had 2 Harvard teaching oncologists sitting next to an OB-GYN who she herself has had breast cancer. And what they all say is, as of now, every person who's been cured and treated for cancer deserves a conversation about risks and benefits of hormones. So when a woman says, I can't have hormones, you deserve a conversation about them. And the other thing is hormones are a big tent. The tent has so many different options, from vaginal estrogen to progesterone to IUDs to all the things. It's a big tent. To say you can't have any of the tent is usually a lack of education. And then the it's not natural thing, I debunk this in my book, of like either is flossing, either our seatbelts, either our socks, either our glasses, either our haircuts. Like if you're going to pick your one, either is air conditioning, right? So if you're going to pick your one natural to die on to be a hormone your body naturally produces, but you take thyroid and you take insulin, right? Like check yourself at this point because it's just really illogical.
Do you have anything to add to that, Peter?
Yeah, I thought I was good at analogies and references, but yeah, Kelly's got me beat. I love her references. They're hysterical. Yeah, I mean, lots of things that women can do if they choose not to. There's definitely homeopathic remedies. There's phytoestrogens that can help with symptom relief. They are not the same as replacing your hormones, though. But it's important to know that those are options for those who choose not to. There's ways of mitigating symptoms. There's also medications available now for hot flash relief. So they do have options for patients who choose to avoid estrogens. But as Kelly was saying, in many women, there's really no reason to avoid hormones. And as we've demonstrated, as studies have now and reanalysis have demonstrated, our hormones never caused our cancers. It's mainly time. Cancers increase with age, genetics, and time. And the presence of them are not the dictators. Those cancers may or may not happen either way, whether they're on them or not. So to find an educated provider that can offer them options, it's always best to have options, but it's not just about hormones. It's about meeting the woman where she is, like you mentioned.
One thing I wanted to ask before I forget is about testosterone and specifically women accessing it. Because I know depending what insurance you have, what provider you're going to, they will not give it to you if you just say to your OBGYN or to the nurse practitioner, I want testosterone. So I learned when I got testosterone, I had to say I had HSDD, which, Kelly, can you say what that is?
Hypoactive sexual desire disorder.
Thank you, because I always get tongue-tied. So I knew like my script of what I had to say, because I go to Kaiser. So I knew I had to say that to be able to get the testosterone. So is that pretty much the case for all? Because obviously if you go to, see either one of your, medical groups, then you get testosterone. So what can women do to access? And is it hard to access it? Outside of their insurance realm?
I think testosterone is the hardest hormone. And to me, like, I love rooting for the underdog, apparently, because it's like, I love testosterone and it's got so many issues right now. Number one, as Dr. Castillo said, the Olympic doping scandals of the 1980s made Congress pass the Anti-Doping Act of 1991. So it's an additional DEA license and some intrastate prescribing issues. So even the wonderful hormone telehealth companies can't do testosterone in every state, right? So we're working on getting DEA de-restricted because none of our other hormones are restricted, right? It's also going to destigmatize the fact that this is not dangerous. I always tell women, I'm not going to make you an Olympic level pole jumper on testosterone. Like I'm just not going to do that. It's not, especially at female doses. Good Lord. So we got to get the DEA off. We're actively having conversations at the federal government level because this was literally an act of Congress that put the DEA restriction on. So it's a pretty big deal to pull it off. Interestingly enough, the DEA and the FDA didn't want it in the first place. It was literally an act of Congress that did this. So when people say, what can I do? What can I do? Get loud, talk to your state senators, tell them you want this deregulated. This is harming Americans because of Olympic sport dopers. Sure. So we got that problem. There's no on label for the FDA. Again, actively working on that. We're probably going to see some movement within this administration. This administration is very interested in testosterone. Of note, most men take testosterone off label, right? So male testosterone is approved for primary hypogonadism. You were born without the ability to make enough testosterone. About 50% of men take testosterone off label. Secondary hypogonadism due to a medical condition, right? So they're trying to expand that label for men, which is wonderful, because a lot of insurance companies, the insurance says they don't practice medicine, the FDA says they don't practice medicine, and then nobody will do anything if it is an FDA approved. So where we get hung up is a lot of insurances say, I won't cover that because there's not an indication. So there's a perfect world and there's a get stuff done world. The get stuff done world is getting this FDA approved for low libido because we do have the most data, probably the fastest to get it through. If we want to get this done and FDA approved, low libido is HSDD is probably what we're going to do. The ideal world is to get it FDA approved for hypogonadism. No matter what your gender is, if your body doesn't make enough hormones, you get to have hormones back. Off-label, compounded, microdosed male, it's all pretty cheap right now, even though insurance doesn't cover it. The most expensive would be the pellets. The highest dose would be the pellets, but there are many people very happy on pellets. There are many people doing appropriately dosed pellets. Men have an FDA-approved pellet for testosterone. So I'm not a huge pellet poo-pooer. There's just some caveats of high dosing. Beware on that. And also expense. So that's the very long story of the barriers to testosterone. My best advice is if telehealth does it in your state, get it via telehealth that does testosterone. It'll say on their website. Joy and Blokes, right now, JOI. Joy and Blokes and MIDI, MIDI, are the two telehealth companies, to my knowledge, that do the largest amount of state coverage for testosterone. And again, they do it pretty cheaply. And then, does your clinician already treat women with testosterone? You can call up and ask your receptionist, hey, does Dr. Jones see women for testosterone? Oh, does anybody else in the practice see? Know before you take time off of work, pay for parking, do childcare, blah, 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 and then sit the person in the face and they're like, they have all the myths of just, right? Know before you go. Because it should be accessible. It should be cheap. It's not, but it's moving very, very fast. It's very exciting. Just 3 years ago, we didn't think we would have gotten the boxed warning off of estrogen like we did. We did. Now our next job is female testosterone. So we're just going to keep working.
I love it. So Peter, your clinic, intimate wellness is the key, one of the key drivers of your business. So if we're talking about, get off the hormones for a minute. So sometimes we can go a little bit farther and there's some either other issues or things we can do either surgically or with other tools. I don't know what the appropriate term is, for a V-fit. I don't know but there are things we can do to sort of do a little vaginal rejuvenation or fixing. So can you talk a little bit about that? Because I know women, there's a lot of stuff going on. Everyone laughs because they're coughing or they're peeing because when they cough, or again, the painful sex, but maybe the hormones aren't completely helping. So can you talk a little bit about those options?
Yeah, sure. Well, so a bit of a mouthful, but so let's start with, say, men's sexual health. They may have medical conditions, they have erectile dysfunction, they may have hypogonadism. Those are all problems that are known to men, and we know that there's therapies. Women have some added elements, life events and aging, childbirth and time, morphologic changes to their anatomy as they grow, as they get older. And it doesn't mean they have to be in their 60s before they notice it. They notice it right away whenever they happen. In fact, just by going from puberty to adult, going through puberty, your genitals change. And sometimes not in the way patients prefer, right? We all have ideals, and it's not anyone to judge what's important for a person. Some girls have underdeveloped labia on one side and 3 times as much on the other side, creating health problems. So, but in other patients, confidence and their self-esteem is impacted by that. Then bring in childbirth. Childbirth alone, if you're having a vaginal delivery, will certainly change pelvic floor anatomy. Sometimes very minimally, and sometimes pretty significantly, leading to prolapse. But the vast majority of times, patients will often present to us just complaining that things don't feel like they used to. They don't, I don't feel my partner. I feel like there's more air noises and traps and air trapping that it makes me uncomfortable. So anything that interrupts that female sex cycle is an interrupter. Is an interrupter to achieving arousal or even climax. So when we have patients that come to see us, it really depends on what their concern is. Is it pain with intercourse? Is it lack of sensitivity? Could be hormonal loss, or it could be because of childbirth changes, or is it a confidence thing that they just don't feel comfortable with the lights on? So really, depending on where the patient's focus and concern is, we kind of go down that avenue of how we can help. I mean, if you wanted to pick an area of common concern is dryness. Dryness leading to painful intercourse or increasing UTIs or pain has to do with environmental changes in the vagina. And that can start early. Like I mentioned earlier, we notice hormonal decline and sexual response decline in the 40s, sometimes earlier. And that could be from either orgasms taking too long or they're muted. One patient described it fireworks, I mean, like sparklers instead of fireworks, or dry as a desert causing pain. And then, of course, if they get UTIs every time they have intercourse, that's a big distractor. So if the dryness is all because of hormonal decline or because of chronic progesterone only or chronic low estrogen use, easy, give them back local estrogen in the vagina. If that responds, great, they stay on it forever. It should just be part of their daily routine. Whereas, like I think Kelly said, like brushing your teeth, just use your estrogen twice a week. Um, the Some patients don't respond. In fact, about 15 years ago, patients, breast cancer survivors, which are stripped of their circulating estrogen to avoid feeding any potential circulating cancer, are basically given the choices of abstinence or using coconut oil. And if that doesn't work, then find something else to do. And that's an unfortunate response for women. And so basically, about 15 years ago, someone decided, you know what, dermatologists have been using lasers very effectively to restore natural function to skin. It's using a controlled thermal imagery, whether it's radio frequency, laser resurfacing, hybrid fractional laser resurfacing. All of these have some benefit to restoring the normal function of skin. And here's what's interesting when you do that. Skin is skin, especially in the vagina. It's just like the skin outside, except it's not keratinized, meaning it's very porous, very permeable. That skin gets very, very thin and less elastic. It can't stretch, which is what causes pain, and then less lubrication because less blood supply. And then combine that with there's a receptor downregulation that happens in the vaginal tissues. Without estrogen, the body says, I'm not making any more receptors for this stuff. I'm not going to waste energy. Whereas in the brain, as Lisa Mosconi showed, that there's an increase upregulation of estrogen receptors in the brain when there's no estrogen. But in the vagina, there's less. So what happens is if you restore skin with energy, you actually replace skin with new skin, not old skin, with all its original properties: thicker epithelium, more collagen streaming, more elasticity, more vascular supply and permeability. So just lasers alone have come a long way in the last 15 years in restoring sexual health, vaginal environment, reduction of UTIs, and allowing women to resume sexual activity without fear of pain. But then there's all kinds of additive things that you can always do. Red light therapy is up in the upswing, called photobiomodulation for increased blood supply and collagen streaming and mitochondrial support. Um, so we offer a lot of these things based on the patient's particular needs. Yeah, I can go on and on. Like I said, we believe in options for women. It's not about this is my one hammer and everything's a nail. That is not the way that sexual health nor women's health should be.
I love it. We're running out of time, as I knew we would,
Yeah.
because there's so much to talk about. But so, two final sort of big, juicy questions so my listeners can go away feeling empowered. One is, I'll direct this to you, Kelly. What would you say to the women listening who, they don't have access to you guys? What can be, say, like a punch list of questions that they should be asking their doctor, or how to find the appropriate help, or sort of how to get started on their journey? What would be your best advice for them?
Do a lot of your education at home, podcasts, books, etc., because the 10-minute doctor visit is not the place to learn anymore.
Mhm.
And to think otherwise is not modern medicine. So get your education, kind of understand the zeitgeist, understand menopause, understand perimenopause as much as you can. I'm not asking everybody to go to medical school. I'm just saying, like, understand these things aren't trying to kill you. Understand they're safe and effective. Like, to kind of just get a baseline. I like, as far as a reference goes, I like ISWSH. So the International Society for the Study of Women's Sexual Health, ISSWSH.org, ISWSH, if I did the acronym properly. Why I like them is, and you can go find a provider. You type in your zip code. It'll tell you the people near your zip code, right? So I think they are the best because they sit in the Venn diagram between sexual health and hormone health. Because sex med doctors understand the important role that hormones play in sexual responsiveness, sexual arousal, sexual desire, lubrication, erections, all the things. And so if you're a sex med doctor, nurse practitioner, PA, by and large, you understand hormones are safe, hormones are important, blah, blah, blah. And I say that over. Another good one is the Menopause Society, menopause.org. They also have Find a Provider. Not everybody in there is sex med trained. Not everybody in there is testosterone trained. Not everybody in there even prescribes hormones, even if they're menopause certified. So I would say that's my second pick, but my first pick would be ishwish.org.
Okay, thank you for that. I want to ask you both, from your differing perspective, female, male, how can women have, or their tips on how to have a conversation with their partner to say, this is what I'm going through and I need support? I know this is really hard for women to do, and I put myself in that camp because, I hit a wall once and I was like, you guys can't keep saying mom's crazy, and that they told me something 3 times I didn't remember. And then especially with my husband, like not wanting to have sex, which is a huge thing. How can we empower women and equip women to have these conversations so we can really release the shame and the stigma around it? We know it's super emotional. As we saw in the M Factor movie, they interviewed that sweet couple, and they talked about their experience. So if you could each, maybe Dr. Castillo, start in our couple minutes that we have left, little quick advice for the ladies listening.
Sure, sure. Well, as Kelly mentioned, education is first. You have to be aware of that this is what's happening and this is what's happening to them, and speak to their partner directly about, listen, it's not you, it is me. There's something going on that I don't understand. And just like in pregnancy and men's role in pregnancy, they can't possibly understand what the woman is going through, but they're in it together, and they have all the tolerance and patience in the world for that patient, for their partner, because they understand that there's something changing their body and that they've got to go along for this ride and be supportive. But because both men and women are so clueless about menopause, they just don't understand what's happening to their body. It creates a lot of discourse, not just sexual discourse, but emotional needs aren't being met. They're not facing each other, so they really have to both understand that this is something they need to go through together. No different than in pregnancy. Be more understanding. If she says it's too damn hot in this room, believe her. Open the windows, and then have that open conversation. What I find helpful, at least what I do in my practice, is when I have patients that are struggling with their partner, I say, you know what, bring your partner with you. We used to have no partner left behind events to educate the other half on what's changing, so they can understand why they're coming to see me so often. Um, and I think just an open dialogue, an open conversation, and as Kelly mentioned, do your research, go in prepared. When you go see your doctor, start with the wants, not just your immediate needs. What do you want to feel? How do you want to go through this? Don't just go in because you have incontinence, because that can be addressed very quickly. But the wants are the ones that I always find were the last question they always ask before I left the room. I call the door handle question. Bring it up first. If that's important to you, talk about that first.
Is there anything you want to add, Kelly?
Oh man, that was so good. I ask all my patients their 6 and 12-month goals, because really kind of focusing on like, where do you want to get with this more than just like my vagina's dry, right? Of just kind of zooming out to be like, in a perfect world, where do you want to be, right? And for discussion with partners, in an ideal world, you're going to talk about sex way before there's any problems with sex. I value our sex life. Our sex life is important to me. Last night was super awesome. We should do that more often, right? Just like little compliments about like sex life is important, blah, 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 blah. Because what everybody realizes about sex is when you talk about it, like nobody dies. And then you're like, oh, nobody died. And you're like, yeah, you don't die talking about sex. And so you talk about it when it's good, because inevitably there will be bumps. There will be erectile dysfunction. There will be menopause. There will be children who have needs. There will be work challenges. Like everything in life is there to disrupt sex lives, right? And so it's like, if you have the extreme benefit of talking about it when it's good, then it's less deadly when you're like, hey, our sex life is really important to us. We deserve a good sex life. Lately, I've noticed, right? I feel, I'm experiencing, not you. It's always I and we. Is a lot less threatening of a way to talk about things where you think you're going to die.
It's a really good way to put it. You're not going to die if you talk about sex. We've hit our time, and I'm so bummed because I want to talk to you all for like another hour. But so we started off with our question, and what this is, this whole podcast episode was about, like, everybody deserves to have good sex. So did we answer the question? Everybody deserves, but can everybody have good sex or great sex?
If they want to. I think important for me is like, if you don't want to, I'm not here to make anybody do what they don't want. And if you are in a relationship that started because of sex and you don't want to, that still is something worth addressing, because that relationship started out sexual and both partners' needs do need to be addressed and talked about. Right. And so to me, again, it's not to get everybody across the finish line at the exact same speed. It's just to really start talking about an incredibly common experience that we all think we're going to die when we talk about it. It's like, you're not. And it's a fascinating topic. It's so fascinating.
I know. We could talk for a whole other hour. Dr. Castillo, final words?
Yeah. Sexual health is really a very independent individual choice, and how we all know couples that are not sexual, and that's okay. If they're happy, they're happy. It's not about sexual dysfunction is only if it bothers the person, right? So it's really, if those who want sex, yes, there can be ways of having better sex. But I think something to other think about, and this is something I brought up at a national convention in Acapulco a couple of years ago, that I mentioned to a room full of OBGYNs that didn't quite put two and two together. We put a speculum inside and we do pap smears and we don't ask them about sex. And then we notice atrophy, but we don't do anything about it, or we give them estrogen. But one of the things that they should be aware of, and patients should be aware of, sexual health is a biomarker for their longevity, for the long-term health. So don't just think about it for now and just having great sex. If that's declining and changing, that's also a sign of things that might be coming that are going to affect their longevity and their health, their cardiovascular health, their cognitive health. Why the reason why we started treating men and women is because both, there takes two to tango. So if you only address one, the other needs help as well. So just think about it as something that's also a biomarker, not just your blood work, as a sign of your health. And if it's important for you, and then seek help. Awesome.
Well, we have got to wrap up. I also want to give a plug to Dr. Kelly Casperson's book. And I had that was like, it feels like this was ages ago that I went to your book launch event here. But Kelly's
like book, 6 months ago. I'm like, it was a long time ago.
It was a long time ago.
Is my book still relevant? Yes. But it's wrong because we had a boxed warning on estrogen when that book came out, and now we don't.
So
things updated version. Fast.
We're good. And then this, and then meta world things are moving fast. We're going to link this in the show notes. But very quickly before we end, let everybody know where they can find you, support you, and get more information. Kelly, go.
KellyCaspersonMD.com. Instagram is KellyCaspersonMD. First book, You Are Not Broken. Second book, Menopause Moment. Podcast, You Are Not Broken.
Dr. Castillo.
Awesome. Yes. SwanMD.com. We're located in the Bay Area. We have 2 practices. Um, our our Instagram handle is Swan Med. I don't have any books yet, but hopefully we'll one day soon.
Oh, Peter, you need a book,
right?
Absolutely.
I block every Tuesday.
Is that the rule? I got to block a whole day.
This is the rule. Books don't write themselves.
No,
That's
they
true.
sure don't.
They don't. You both, it has been an absolute pleasure. We're going to link everything that we talked about in the show notes, the resources, books, websites, Instagrams, all that kind of great stuff. So you can, if you're not already following both of these fabulous doctors, you will be. And just thank you so much for sharing your time, both of you today. I know time is of the essence. You actually see patients and you're not sitting at your desks all day. So I just really appreciate it from the bottom of my heart. And I know my listeners will too. And so hopefully we'll see you soon. Peter, I know I'll see you soon because you're in the area. Kelly, like we were saying, I was hoping my kids would go to UW and I'd get up there more, but no, but I'll have to see you at the next something
we'll see you in
on
New York.
The Menno Trail. Yeah, we'll see you in New York.
Exactly.
But thank you both very much for being here. It has been an absolute pleasure.
Thank you.
It's been an honor. Thank you so much, Jen. Great to see you, Kelly.